We're talking to Dr. Ralph Benson, a urologist, and of course, Dr. Benson, before we had our second commercial break, you were talking about some of the things associated with this new treatment. Let's allow you to continue that discussion as well as to talk about some of the national or the magnitude of this as an issue during this last segment of the show.
Surely. I think it's important to grasp the magnitude of the problem, not only in the United States, but worldwide. If we look at the number of men who are over 50, by year 2005, there'll probably be 40 million men in the United States over the age of 50. And if 50% of those patients are having trouble with their prostate that's not a malignancy, but enlargement, this is a tremendous number of folks. Now, classically, in the past, what we've seen is that probably 75 to 80% of men will say, well, yes, I'm being troubled, but I can manage that and that's okay. Last year, for instance, there were probably 1.5 million men that opted for medication. Those numbers will probably even increase a little bit, I think, as awareness of help is there. The transurethral prostatectomy, the gold standard, actually has decreased in numbers. There were probably in 90 to 92, about 500,000 of those operations done a year. That's down to about 250,000 today, I think because of some of the new technologies. But the issue in terms of the magnitude of dollars is enormous. If we look at benign prostatic hyperplasia in the world and what's being spent, it's well in excess of $10 billion, probably $5 billion in this country alone. And when we look at prostate problems and the transurethral prostatectomy in terms of Medicare dollars, it is the most, the largest category of dollars that's spent certainly on men, and it's almost 2% of the Medicare, total Medicare budgets, which is, doesn't sound like much, but it's really an enormous amount. So in the future, as we all age and as we all live longer, this is going to become more and more of a problem. And I think we truly are going to have to look at new treatment modalities that keep us out of the hospital and keep this not an $8,000 to $10,000 operation. So that's why we're all enthusiastic about some of the new modalities. And I think that importantly, and I may change my tune in the future, but I think not, that we really need to translate this into the office as best possible. And I also think we need to look at cost in terms of patients being able to return to work. I mean, if we look at 500,000 men getting a TUR, that's transurethral resection, that's 500,000 men who can't go back to work for 6 weeks. I mean, you've got
that's generally time 6 weeks.
Yeah, you've got to fold that back into the number of dollars that are productive dollars, I think, that are lost in our country. Overseas, this is going to be more and more important. As there's, in this country, there doesn't seem to be a difference in incidence of benign prostatic disease in African Americans versus Caucasians versus Orientals versus Hispanics or whatever. Overseas, there tends to be a feeling that that's true, that there's less of a problem, for instance, in Orientals. I'm not sure that that's not cultural. I think that we may see that again as people realize that there are easier techniques like the tuna technique that are evolving, that they may say, well, yes, I'm really tired of getting up 3 times a night, and I'd like to empty my bladder, and yes, I'll go in the morning and have somebody pick me up and take me home, and I'll be fine after that.
It's that simple now with the processes that
it truly is. Patients come in the office, they're given an injection of a little narcotic to take the edge off things. We do a block. We infiltrate around the prostate with a little local anesthetic, and then put a little local anesthetic jelly in the urethra, and we can go up and we can insert the needles without any problem. And so there's no recovery time and that kind of thing. So I think in terms of patient acceptance, once people know that some of these techniques are available, that they'll be more enthusiastically embraced than in the past.
Well, Doctor, you know, we've got about a minute and 45 seconds before the end of our show today. And let's allow you over the last minute and a half that we have here to perhaps make a pitch in terms of what do you know, what ought to be done, of what you can say to our audience this morning as to why they ought to take advantage of this new system or whatever.
Surely.
Let's do that.
Surely, but if I'm going to make a pitch, let me do this. And let me say that I think that clearly everybody over 50 who's experiencing any change in urination ought to see their physician. And I think they ought to have a PSA. And I think that with any high-risk groups, like African Americans or anybody who's had any prostate cancer in the family, we ought to shift that back to age 40. They need to come in, they need to have their prostate evaluated, and they need to have a PSA test done. They then, I think, need to sit down and hear the alternatives. And I think that we need to stress the minimally invasive techniques because they're single event therapy. And the reality is, with the tuna procedure, it's a one-shot deal, if you will. And if it doesn't work, we have lost time and a bit of money, but we can always go back and trim things up or whatever. So my feeling is the patient needs to rule out cancer, very importantly, hear the alternatives, especially the new things, and then make their decision.
Well, Dr. Benson, let me, over the last 10 or 15 seconds that we have here, let me thank you for coming by and giving us that excellent information about prostate problems and new treatments, especially this TUNA, the tuna treatment today. And let me encourage our audience to tune in again next week for another informative edition of Comments. Thank you and good morning.